The third one.
Okay. So what we're going to do this morning then is start to think about non-infectious diseases. Now, whereas with infectious diseases, we can kind of follow, I'm going to move that away because I'm going to trip over otherwise, we can kind of follow Rachel's online and Katie's online. There we go. So it's a full house. Let's say with infectious diseases, we can kind of follow a profile because it is basically a microorganism that causes some kind of pathogenic effect. Now, with non-infectious, what I would say from the beginning is this is not by any stretch the tip of the iceberg. We're basically going to chat through a couple of different body systems, and hopefully, I realised it's a while ago, but hopefully your functional anatomy will come flooding back to you. But if it doesn't, then just shout and we can kind of go through the pathology. Because what we're going to focus on really is look again at this main learning outcome, so etiology, pathogenesis, progression and treatment. So we have got another lesson in a few weeks, so we're focusing on cardiac. So today we're kind of doing systemic effects of disease, but focusing more on the alimentary system and a little bit of kidneys. And again, hopefully, it's going to give you a bit of tips with your assignments, which obviously you've still got a good 10 days before that's due. Has anyone got any assignment questions? Not 10 days, next weekend is due.
Sunday.
Has anyone got any questions about it?
We could do 10.
Any major worries? You kind of ish.
Was the thing? How that?
Yeah. So best thing
Just
to
talking about One Health in general.
So you need to apply it. So what I would suggest you do is if you go back and have a look at the BVA report on One Health and just pick an area that's relevant to your disease. So it might be careful use of antibiotics. It might be efficient use of vaccinations. So I would pick something that's relevant to your disease and then basically articulate how it relates to it. So I'd say the most obvious one would be something like, say doing Parvovirus. We know that the critical thing with Parvo is early vaccinations because it affects obviously the puppies at 8 to 12 weeks. So those that don't have their vaccinations tend to be, or the ones where their mothers aren't vaccinated, tend to then be the group that are hit most majorly by Parvo. So One Health approach for that would be, right, well actually let's look at how we're vaccinating, how we're making sure that people are kind of breeding well, how are they implementing good start of life care. And then you would think about, okay, if we're thinking about appropriate vaccination in animals, how is that then similar in humans or that kind of thing. But have a look at the BVA report because it breaks it down nicely, and it's also a lot of it's in infographics. So it's, although it's a big document, it's quite straightforward. So pick something like that, and that will also give you. They've got the nice, which I know Fern showed you again last week, the nice infographics that kind of go through all the different factors, and you could then pick a couple of those and chat through them. Just touch on it. Cool. So first question to you guys. We always do this. But if you had to describe what was a non-infectious disease, bearing in mind obviously we've covered epidemiology now, we've covered infectious diseases, and we've covered isolation analysis. What is it about a non-infectious that's different? So guys online, if you want to use the chat, oh bless you, Katie's on the A303. Rachel, are you okay? Got a hand up.
Can you hear me?
Yeah.
Oh, sorry. I was just wondering for the assignment, if you could just explain the difference between the epidemiological principles, etiology, and the pathogenesis, because when I've looked it up, it all just says the cause.
So it's all right. So the etiology is the cause. That's the causative agent. The pathogenesis is then how that agent results in clinical signs. So what it does, basically how it causes pathology. So it might be that it invades the body system. It might be that it is intracellular, and therefore that's how it promotes it. So basically, how does the presence of that disease or that pathogen cause the pathology that we're seeing? And then what you might find is that then gives you the opportunity to pull out your clinical signs quite nicely. And then epidemiology is the route it takes to transmit itself. So thinking about your portals of exit, your methods of transmission, is there anything about the population that predisposes them? So we just talked about Parvo. So Parvo, you could say that the kind of epidemiology is that it has a clustering ability. It affects animals that have a weakened or non-developed immune system. It targets puppies at a certain age. So that would be your epidemiology. So trying to kind of pull out those bits about, is it endemic? Is it something that it clusters and therefore it's epidemics? How, say, factors of the population that influence the spread, those kind of things. So etiology is causative. Pathogenesis is how the causative then results in the clinical signs, and epidemiology is how it's transmitted between hosts.
Oh, okay. Yeah, that's good. Thank you.
Very problem at all. I like it when people talk. It's good. Makes my life easier because I forget that screen's there. Okay, so non-infectious. I'll give you another kind of minute or so to have a think. Okay, who wants to start us off?
Caused by pathogen.
Yeah, good. So disease is not caused by a pathogen or a microorganism.
Can't be spread.
Can't be spread. Wonderful. What else? Guys in line, what else can we add to it? So it's not caused by a pathogenic organism, microorganism. It can't be spread.
It can be inherited.
Yeah, good. It can be inherited. That's a really good one. If it's not spread by a pathogen, what tends to be a cause of it?
Is it like
Yeah,
like something that's not worth
yeah, fantastic.
attacking its
Yeah, lovely. That's a nice way of phrasing it, like a misalignment or an error in the body, a deterioration, a clinical deterioration, something that's not functioning correctly as it should be. Wonderful. Okay. Yeah, so there we go. So these are our main definitions. So a disease that isn't caused by microorganisms, and that's the key thing, isn't it? That we know that our infectious are caused by something that is either an endemic microorganism, so where it kind of overgrows and disrupts the normal kind of balance of the body, or we've got an invasive microorganism like a bacteria that enters the body, causes significant changes or at least some change to the internal mechanisms, is recognised by the body as foreign and then stimulates an immune response. Whereas with our non-infectious diseases, absolutely, we're thinking more about the normal metabolism or the normal functionality of the body. So the clinical signs that we're seeing are related, as Celia said, this kind of misalignment. So something's gone wrong internally, and the clinical signs that we're witnessing are kind of focused on that. Now, it could be, it says there, it could metabolism, for example, it could be hormonal. So we've got too much or too little of a hormone being produced. And if you think back to functional anatomy, when you were talking with Bev about kind of the homeostatic processes, the fact that normally if there's too much or too little, the body can compensate, it can kind of reset itself. And then that prevents ill health from occurring. With our non-infectious diseases, we find that ability to kind of self-correct or reset for whatever reason is missing. So whether we've got too much present or not enough, or potentially like arthritis, we've got that developing deterioration, and that's then going to cause the pathology. Wonderful. And as I say, it may result from a problem with one or several body systems. And one of the challenges when it's several is that we know that a lot of the body systems are kind of interchangeable or connected. So with something like osteoarthritis, we might find that our animal, for example, has osteoarthritis in their hip joints, but because they've got discomfort there, they're compensating or they're shifting their gait, so the way they walk, to their stifle or their tarsus. And suddenly you've got that kind of snowball effect. The initial site of problem then develops more and more elsewhere. Katie's also said it could be caused by genetics, which is great, as what Shalise said, but also lifestyle. And that's another really good point, that potentially it could be that the individual animal has maybe a less desirable lifestyle. Now, we tend to think about, for example, with arthritis, we tend to think that maybe it's due to obesity or poor kind of management of kind of healthy conditions, but equally it might just be actually fatigue induced, or it might be strain. So a lot of our non-infectious also tend to be age related. They're not always, but often we find this natural deterioration of the systems, which makes it more challenging. So in terms of your kind of types of non-infectious then, we've got our acute, which tends to be our short duration. And often these are linked more to a trauma or an insult to the body system. So something like acute kidney failure, for example, we're getting to that time of year where we've got our ethylene glycol, so our antifreeze. Unknowing to it, a cat goes along, picks up the antifreeze, licks its feet, causes an acute renal disease. Now, the thing is with the acute is you can find that in the acute systems, because it's a short-term insult, as long as that organ has functioned normally before, an acute non-infectious may well be fully reversible. So something like acute renal disease, and I say the ethylene glycol example, the cats are incredibly poorly, but if we can then either reduce the agent that's causing that, or at the very least we can provide supportive treatment to allow kind of that extra bit of support until the body recovers itself, with acute injuries, you tend to find that they recover quite quickly. So almost similar to kind of our acute pain and our chronic pain. It's linked to a specific pathology. The animal heals itself, everything should return to normal. Whereas with our chronic, these are our longer durations. And in some ways, our chronic ones are harder to manage, because what we find is, again, we know that the body system has got lots and lots of compensatory mechanisms in place. But with something like chronic liver disease, for example, the liver can compensate for up to 60% damage. And at that point, you don't see any clinical signs at all. So when they're showing clinical signs, that basically tells you that the body has reached its limit. It's got to a point where it can't compensate anymore. And that's why you're now seeing the ill health, because whereas before, potentially, it could redistribute the bile production, it could, give a little bit more of healing in this area than over others. If we're seeing clinical signs with our chronic, it generally means that our animal has already reached that limit. So in terms of kind of prognosis, unfortunately with our chronic health conditions, we can support the animal 100%, but we generally can't cure them. And obviously from a nursing point of view, this puts a very different emphasis on how we approach our patients, but also maybe how we manage our owners. So I always find it really sad with our really kind of stage 4, really chronic kidney disease cats, because at that point you cannot say to the owners, we're going to wave a magic wand and your animal's going to be fine. At that point you're treating the symptoms, you're trying to improve quality of life, but because it's a chronic non-infectious, there's no magic wand, there's no way of reversing the damage that's happened. So with our non-infectious, because they tend to be more, as I say, they can be more delayed in their clinical signs, or they might be related to different body systems, we tend to do what's called a differential diagnostic approach. So we're looking, rather than trying to pinpoint the presence of a specific pathogen, we're looking to see actually which part of the mechanism, which part of the metabolism has been affected. So it might be, for example, that we want to, say we've got a kidney cat, we might be looking at bloods to see actually what waste products we've got remaining, how well the animal is processing those waste products. It might be that we do an ultrasound to actually look at the quality of the kidney. It might be that we do An X-ray, for example, is again to look at the size and the position of the kidney. So it's not one obvious option. So we're very much trying to patchwork. So hopefully in your diagnosis for your non-infectious, they're probably a slightly bigger section than your diagnosis of your infectious. As infectious, we look for the agent, yeah, it's there, great. With the non-infectious, we're kind of doing this patchwork and all this puzzle to kind of put bits together. Okay.
Oh, yeah.
Oh,
Yes, it's
a choice. Oh, okay. Were they really poorly?
Yeah, it's schizophrenia.
Okay.
Yeah.
Antifreeze is not a...
It's not a beverage.
No, it's really not advisable. It's not a good thing to do. The other thing to remember with non-infectious diseases, and this is a little bit different, is the way we approach treatment is often based on clinical signs. So whereas with our infectious diseases, we're treating the pathogen, with our non-infectious, as I say, because they can be more subtle or because they affect multiple body systems, generally with our non-infectious, we're treating the clinical signs that we witness. Now, if that's something like acute kidney function, and it might be, say we've got the ethylene glycol, and one of the things it can do is cause quite acute kidney kind of disease, what we might be able to do is actually get rid of the antifreeze and then support the kidneys until they can heal. Sometimes that's not possible, particularly if it's a chronic disease, because the pathology at that stage is irreversible. So we might find that actually we're giving treatments based more on the clinical signs. And at that point, this makes it, not for us, but it makes it, I thought it makes it a little bit more straightforward. Because instead of trying to match up conditions, you treat the symptoms. So I don't know how much have you done with Emma in pharmacology? You started looking at specific groups, yeah? No. Okay, that's fine. But for example, something like if we do like a cardiac patient versus a kidney patient, in a cardiac patient, let's say our problem is that we've got congestion or we've got poor return of blood flow. Now that might be the same problem in our renal patient, but for a different area. So often the medication that we give patients for things like renal and cardiac are often very similar, because what we're addressing is the clinical signs. Same goes for patients who've got maybe GI problems versus liver problems. Again, what we're doing is we're looking at those common clinical signs. And if, for argument's sake, we've got a patient that's experiencing nausea, well, there's only one medication we can give that will prevent nausea. So again, our non-infectious are quite, in a kind of a nursing point of view, are quite nice, because it means we learn it symptomatically. So again, with your treatments, your medications, all those things, we're kind of trying to work out what the major concern is and treating that major concern. Whereas with for example, with our bacteria, we know that there's an endless supply of antibiotics, and we're trying to match up the antibiotics by suitability. Whereas with our non-infectious, we're looking at clinical signs and then responding to those. Make sense so far? Okay. The other, as I say, this is just reiterating. So they don't necessarily have a specific treatment, and sometimes this can make it a bit frustrating, because if you've got certain times when I've seen quite chronic kidney patients, for example, or chronic cardiac patients, and you just want to have that magic wand. You want to give them that medication that's going to fix it. But with non-infectious, by their very nature, we're not able to just kind of, as I say, have one particular approach. So with your treatment, it tends to be that we focus on the symptoms that are causing the biggest concern, or the clinical signs that are causing the biggest concern, and we treat those to, first of all, alleviate the effects of the non-infectious disease, but often it's to improve the quality of life for that individual animal. So again, it's a slightly different emphasis. So if I, for example, have a kidney cat who, because of their kidney disease, has become nauseated, has stopped eating, has become dehydrated, whilst I could argue, well, I need to treat the kidney disease, actually my priority is to rehydrate my patient, to make them stop feeling sick, and then to get them to eat again. So it's just a slightly different kind of approach to them. So with that in mind, what I thought we'd just go through a few different examples. As I said, try to keep it to things that you are going to have in your assignments. If you haven't got quite a lot at this stage, then you can pinch the answers, and if you have, hopefully it will just encourage you that you're on the right line. So first one then is our renal disease. So with your renal disease, this is something that you will come across a lot in practice. Unfortunately, it tends to affect a lot of cats particularly, and it tends to be our geriatric cats specifically that we associate renal disease with. Now, at the very, very beginning, it's worth remembering that renal disease is one of those diseases that the body can mask for a very long period of time before clinical signs are seen. And the reason for that is at 75% of damage, that's the point you see clinical signs. So you may well find that your cat, let's say for argument's sake, has 40% damage, the body will basically keep compensating. And it's the kidneys are incredibly good at doing this, that they'll keep going, 75% hits, and then they suddenly give up. So from a kind of clinical side of view, that can make our nursing quite challenging because, again, we're approaching an animal that is already compromised and is already unwell at the point that they see these signs. Having said that, there is a whole process that we can apply, and hopefully those of you that have chosen renal disease will have found this. But the ISFM, so the International Society of Feline Medicine, has produced basically a staging of kidney disease. So we used to have it in practice on one of our doors, so we could always refer to it. But what it does is it looks at all of the different factors, all of the different compensatory mechanisms, and tries to work out at which stage our kidney patient is. So can anybody, those of you who do renal disease, can anyone tell me what kind of things we can assess in cats to see how well their kidney function is? Think about kidney disease, kidneys from last year. What do our kidneys do?
The urea and creatinine.
Yeah, good. So our urea and creatinine, which are two of our waste products that the kidney normally processes. So yeah, so we can do a blood test that gives us urea and creatinine. What else do our kidneys do? What other function do they have other than waste product removal? Yeah, good. Yeah, no, you're right. So they can do salt level. They level the salt, or they level the fluid retention, don't they? Yeah. So another thing we can look at from that kind of thing would be blood pressure. So if our cat isn't producing or isn't retaining, or is potentially retaining too much, then we'll find the blood pressure increases. The other one is concentration of urine, because again, with the water side of things, normally it's our kidneys that decide how much water is staying in circulation and how much water is going out. And what we find with our kidney cats is they are unable to concentrate their urine because they basically haven't got the kidney function to hold those water molecules in place. So if you remember from last year, you've got your Bowman's capsule inside your nephron. So kind of almost like your sieve with various different holes in it. So as the kidney becomes damaged, and as the tubules specifically are damaged, you find those capsules deteriorate. So instead of having lots and lots of almost like having a tight sieve where you kind of can pass through small amounts and then your bigger molecules stay in the urine, you've suddenly got nothing. So we might find that they can't concentrate the urine for starters, but equally things like protein that normally stay in circulation start falling out. So in terms of how we can monitor it, whilst we've said it's 75%, you've suddenly got three things that you can do. So you can take a blood test to look for urine and creatinine, which tells us whether or not our kidneys are functioning correctly in terms of waste products. But you can also do a urine test to see what our concentration of our urine is and see if there's protein in there. And then if you're still not sure, you can do blood pressure. So this is one of the kind of benefits, I suppose, of having a disease that is normally compensatory, because what you can do is if you have animals that you think are going to be predisposed, you can then kind of put these things in place. So just to give you an example, so one of the things we used to do when I was in day practice is we would do a senior cat clinic. So we'd have our cats that come in every 6 months, and as standard, we would take a urine sample and we do blood pressure. So the fact that we've got almost like with everything else, you've got that kind of clinical parameter where you're observing. With something like kidney disease, that's really helpful because you've got that kind of monitoring approach. Because as I say, the key thing is that once that damage has been affected, the kidney can't compensate. Now, the other thing that's worth remembering with kidney disease, and we're going to chat through a couple of different examples in a minute, but the kidney, whilst you've got the nephron and you've got the cortex and you've got all of those bits that you would have gone through with Ben last year, it's very much an organ that works together. So if one part of the kidney is affected, you will find that the whole function is affected. Okay, so we'll go through this. Okay. So with that in mind, then, when we talk about kidney disease, we've got a couple of different terms, and it depends on which part of the kidney is being affected. So first one then, really, really general, is nephritis. And nephritis is basically inflammation of the entire kidney. So obviously we know the prefix nephron, meaning kidney function, and obviously itis, as hopefully we're happy now, is inflammation. Hopefully. The rest you can come back to, but hopefully itis is one that you're comfortable with. So we've got, so inflammation of the kidney specifically as a whole entity. The next one then is glomerular nephritis, which is basically inflammation of the glomerulus specifically, so that Bowman's capsule. And if our cats have a inflammation of that, that's when we see their filtration ability is compromised. So as I say, their ability to get rid of those waste products in the urine, the ability to keep protein in circulation, the ability to kind of regulate urine concentration, all of those things are significantly impacted. So our cat really can't concentrate urine, and if there's huge gaps in the nephrons, then the protein starts escaping. And then the next one, which is quite difficult to kind of pinpoint, and often we don't get to this stage of diagnostics unless we're doing kind of an ultrasound, would be our interstitial nephritis. And this is where you've got inflammation of the tissue that sits between the nephrons. So really, really specific. But in terms of our clinical signs, they're all very much the same. Because, as we said before, the kidneys all work together as one entity. Now, what's always quite fun with our kidney patients is that the clinical signs say it's all or nothing, but it doesn't mean that both kidneys are affected. So obviously we know that most animals will have a pair. Hopefully you guys have got a pair of kidneys. But it can be unilateral or bilateral. So it could be just one kidney that's affected. And often with our acute kidney, if it's a trauma, so say I've had a cat that's involved in RTA and the collision is on this side of their body, you might find that, let's for argument's sake, the right kidney is affected. But the clinical signs will be systemic. It will behave as if both of them are affected. Equally, if we've got something like chronic kidney disease that affects both kidneys, it's not going to mean that we get double the clinical signs from those kidneys. They're going to behave very similarly. So with our diagnostics, we're almost trying to work out whether it's both sides that's been affected or whether it's one. Yeah. So let's go through some specifics then. So the first one then is your acute renal failure. Now, as I said before, this can be reversible because normally it's associated with a specific insult or a specific trauma. So some examples we've got there would be severe dehydration. So where the animal hasn't had enough fluid, and as a result, the kidneys are not being perfused appropriately. So remember, perfusion is to do with the amount of fluid or amount of blood flow specifically that goes to a particular area. But with perfusion, we're thinking about hydration as much as oxygenation. So our kidneys basically become really dried out, and we get a lack of blood flow to those areas. And as a result, we start to get necrosis of the kidneys. Now, if that's short term, and then the kidney can actually become hydrated again, what we find is because the kidney is very good at recycling and restoring itself, we can put the patient on fluids, hydration goes back to normal, and after a few days, weeks or so, the kidney will basically repair itself. Same goes for circulatory failure. So if it's that we've had a major trauma, so again, argument's sake, And let's say we've had a dog that's been, what should we do other than RTA, has, what do we have the other week? A greyhound that had lacerated its the artery in its foot, just like you do, because it's fun. If that ends up being a massive hemorrhage, again, the circulating blood would have dropped. So potentially, if there's poor blood flow or poor blood pressure, that kidney, if it's not getting enough blood, could then also become poorly perfused. So clinically, it would be the same as dehydration. So it's either we've taken the fluid away or we've taken the blood away, but the same thing occurs. So it becomes necrotic. And again, if the kidney can correct itself, particularly if the blood flow is returned, then we find that the clinical signs are short-term. So we mentioned ethylene glycol, but does anyone know of any other poisons that affect the kidneys in cats? Paracetamol, wonderful.
Lilies.
Yeah, good. Lilies, another good one. Lilies is a fun one because it also causes crystals to form in the urine. So if you can, so if you can see them, it takes a while, but they will shake crystals.
And my brother-in-law's sent a bottle of wine that I don't drink and lilies, and I was like, I've got that. So they actually.
So cut the stamens out next time.
I don't. Ceiling is. There is no. That's also.
Yeah. Put them in a bin. Yeah, for future reference, we cut the stamens out. But yeah, no, it is.
Come into the chimney next time.
Yeah. Oh, whatever. I'm on broken.
It's okay. Lilies is a good one. I'm always amazed how few cat owners know that Lilies is poisonous though.
Yeah.
Because like one of my friends, she's actually only got the one cat. She's got a couple of dogs, but this cat is everywhere. And she posts. Yeah, they have to eat them. But Patsy's literally all over the place, and she posted on Instagram the day a photo like, I've got these amazing lilies in my house, and I was like, but you've also got a cat, like
Yeah.
But yeah, they have to ingest it. But it can often what happens is when they
Rub up against.
and then they grow.
But it's everywhere. So I think it's.
Yeah.
It's when they come in, they say, oh, we're not sure which one cat's got like. It's that they're like.
We actually had it was really, really sad a few weeks ago. But now we had a Friday night. It was Persians, and they had 3 cats, and one of them had ingested the pollen, and for whatever reason, I don't know whether it was euthanized or whether we just didn't get it quick enough, but that one actually passed away from the pollen. So then on the Saturday when I was in, they wanted both Persians to be blood tested to see if they had ingested it as well. It turns out neither of them had it, and I probably could have told them when the first Persian bit me while I was trying to take blood from it. I was like, I don't think you're unwell. But it was one of those situations where I was trying to be really compassionate and go, oh, it's okay. In my head, I was like, I'm taking blood from you and you've just bitten me. But yeah, it's tricky when there's lots of them. Sorry, I don't have COVID. I've had 2 negative tests. This is just child learning. Right, next one then is urinary tract obstruction. So what would be our most common cause of urinary tract obstruction in a male cat?
Crystals.
Yeah, wonderful. So if they've got urinalysis, so crystal, and it blocks the urethra. I always get this wrong. There's two ureters. There's only one urethra because, this is my mistake, there's only one urethra franklin. I know it sounds stupid. Put it together. So it blocks the urethra. So what you find in that situation is you basically get a backlog. So you've got a urolith in situ. It's preventing, obviously, removal of waste. And as a result, it causes congestion back up the urinary tract, specifically in the nephrons, and then causes damage in the nephrons. And that's to do with pressure more than anything else. So it's just the fact, it's almost like you've blocked the end, got all this congestion, and that's creating a pressure problem. Which is one of the reasons why when we've got blocked cats come in, we're always very quick to unblock them, because it can have significant kidney problems. And the last one I said before is trauma. So things like an RTA, particularly if it's an abdominal trauma, it's always worth checking the kidneys. So we're always very good at checking for wounds, we're always very good at checking the lungs to see if they've been traumatised at all. But this is why we do things like blood tests on our RTAs, just to see if they've had any kidney damage. And certainly if they're urinating blood after an RTA, you'd want to make sure it wasn't more of a problem. So with your treatment, for genuine acute ones, it's almost a bit of a time waiting game. So it's symptomatic. So if we can remove the underlying cause, so say for example with the poisoning, if we can give an antidote, does anyone know what the antidote to ethylene glycol is?
Vodka.
Vodka. Yes, wonderful. But yeah, so if we can give our patients vodka, get the cats nice and drunk, I'm joking, but give them vodka, then that immediately removes the causative agent that's causing the trauma. So then at that point, we give them fluids and we give them, we check their dehydration status. Because at that point, what we want for the kidney to do is basically to go back onto its normal process and be well hydrated. Same goes for our circulatory failure. If it is that our cats had a major hemorrhage, and that's what's caused the blood to drop, stop the hemorrhage, give them fluids. So in the short term, these are quite easily managed as long as you can help the kidney correct itself. Because if it's acute, you would expect there to be a much smaller percentage of the tubules that have been affected. So at that point, the compensatory approach should be able to kick in. Okay. Cool. Whereas with our chronic, excuse me, this is a bit more of a challenge, simply because, simply because as we said, because the kidneys are able to compensate, we're generally dealing with a much more unwell animal before we recognise the clinical signs. It's at 75%. So with something like here, that's a really nasty looking kidney, but you can see the difference between the normal kidney and the chronic renal. The pathology itself has changed quite significantly. So our kidneys are going to will have become very scarred, and we might find that actually there's parts of the kidney that have already deteriorated so that they're no longer functioning. And at that point, the kidney itself is not able to almost reset itself. So when we're faced with kidney cats, particularly, we do see kidney disease in dogs, but it tends to be more commonly in cats. You've already got an animal that is already in a state of deterioration. They're already going to be compromised. And what we then have to do is to treat the clinical signs and improve quality of life. Because unfortunately, if we're presented with something like this in practice, there's no treatment available that is suddenly going to reverse it back to this, because the trauma has already happened. So in that case, what we're trying to do is treat the clinical signs, make the cat feel better, and hopefully if they feel better, they'll have better quality of life and they'll generally, they'll have a happier existence. But we're never going to be able to reverse all of the clinical signs so that we can massively extend the life expectancy. So in terms of the clinical causes, there's a whole range. So you've got congenital problems, and I don't know if you guys remember last year, if you watched Pedigree Dogs Exposed, one of the conditions they chatted about a lot on there was premature kidney disease in boxers. So that would be a chronic example. Nephritis, as we said before, so nephritis could be due to, again, an ongoing kind of insult in the sense that maybe there's a poisoning. It could be that there is a lack of blood flow, but equally, and this always feels really cruel, we mentioned before urea and creatinine, which are two waste products that the kidneys naturally kind of process. Urea as itself is actually will actually kill off kidney tissue. So if you've got urea in circulation, it's really corrosive. So it almost like, if it's there and you can't control it, that'll actually lead to more kidney disease, which is quite harsh. Long-term urinary obstruction. You could also put in here things like ongoing cystitis. So those cats that don't necessarily have uroliths or crystals, but their inflammation is causing, what's the word I was looking for? It's causing tenesmus. What is the word I'm looking for? No, I'll come back to me in a minute. But basically, inflammation itself causes narrowing or an obstruction. So you might find then that it's presenting like an obstruction, but it's to do with inflammation. So something like a cat that keeps getting cystitis due to stress, or is high risk of urinary tract infections, the inflammation itself is going to cause that almost the same concern of clinical stress as well. Dietary, do we know of any dietary problems that might increase kidneys?
Vegan. Vegan cats.
Yeah, vegan, absolutely. So if they're not getting enough protein, and also the opposite, so if they're getting too much protein. So you can find if they're vegan cats, they're not getting the protein they need, that can certainly have a significant clinical effect. But equally, our cats that are fed on a high protein diet, the reason for that is if you are eating a lot of protein, you will naturally produce a lot of urea. So you end up with this almost too much waste product. And as a result, your patients, again, are having too much, and that becomes corrosive. We've got things like systemic lupus, which is our autoimmune diseases. So there are a number of different conditions that animals can suffer from, where the own immune system will actually start to attack the kidney tissue. What do we mean by idiopathic?
Unknown cause.
Yeah, good, unknown cause. So there are those patients that will just suddenly randomly get kidney disease, and there's not necessarily a reason behind it. And they're a joy, because you're just like,
Because cats.
I don't quite know how to treat you with. And then your secondary to other chronic, this tends to be cardiac. So our cardiac and our kidney patients tend to swap through. Just because if you've got congestion problems in your heart that's preventing effective blood flow around the body, one of the systems that's not going to be very tolerating of lack of blood flow is going to be your kidneys. So we tend to find that actually cats that have got kidney disease, you might find that they then also suffer from hypertension, which then might increase their risk of heart disease. Equally, heart disease animals, because of hypertension, then may have renal diseases as well. And then what about atrogenic? What do you remember that? Yeah, so atrogenic means caused by medication. So where we've given a drug inappropriately, or tends to be more where we've overdosed the animal. So again, think back to your pharmacology lesson, specifically with your pharmacokinetics and your excretions. We know that a lot of the drugs that we use are either excreted via the kidney or the liver. And again, if you've given something at a much too high a dose, you then increase the chances that you're going to damage. So a few, 2-3 months ago, I was in day practice actually, but we had a dog in with us that the vet, bless him, had got his maths wrong. So he'd given a Labrador-sized dose of Metacam to a Daxi. So the Daxi, she was fine, she was absolutely fine, but she was in precautionary on fluids in case the excess Metacam resulted in kidney damage. And so she was absolutely fine. She was one of those loons that basically she decided to go home because the whole time she was in, she just would chew her catheter out. And after like day 3 or 4, the team was like, do you know what? She clearly isn't getting fluids with us. She might as well go home and drink her fluids because this isn't working. But that would be an atrogenic example. So where you're just giving too much of the same medication and it has to be metabolized. And that over metabolism causes trauma or exerts stress onto the kidneys. Okay, so clinical signs then. And these are all quite specific, which is quite nice. And again, it's worth trying to kind of learn these common clinical signs purely for the fact that these are the kind of things that we're going to be able to pick up in consults. Now, again, obviously, we keep coming back to this time and time again. We're not allowed to diagnose as nurses, we know that, but that doesn't stop us from taking history and asking those questions. So certainly when we used to do senior clinics in my last day practice, you know, common questions we'd ask the owners would be, you know, how are they drinking? What's their eating habit like? How do you know, what's their toileting? And it wouldn't be that uncommon for owners to go, oh yeah, actually, they started drinking a heck of a lot. And they're like, there's lots of accidents in the house. So those are the kind of conversations that you can then go, huh, light bulb. And it does feel a little bit like you're on, you know, you're doing a bit of a drama series, because at that point I'd go, oh, this is really interesting. And in my head I go, okay, I want to do bloods. And then you say to the owner, I'm just going to go pop out to the vet and ask them what they would suggest. And then go out to the vet and go, can I run some bloods for this animal because of this, this and this? And they go, yes, yes, of course you can, well done. And you go back out and go, right, so I've just spoken to the vet and they've just suggested that we run some bloods. Now, not any point is that not me, but in front of the client, it's obviously the vet that comes from. But, you know, as nurses, it's worth remembering these kind of things because, as I say, often it's us that are having the conversations with the owners. It might be us that are taking the phone calls. And whilst we can't be seen to be making that clinical judgment, if you know what things are, I say you will diagnose, but it's that the formal is the vets.
There's clinical side. Lots of diseases, aren't they? So
yeah.
Would you automatically?
Yeah, I mean, when I
like polyuria, weight loss could
be, yeah,
it could be lost.
Yeah, so I would very much have it when I was not so much at vets now because we don't do the same thing, but certainly in day practice, if I was getting these kind of things reported to me, then I would ask the vets if we could do like a general screen, because then if it was kidney, you could have urea and creatinine. Equally, if it was diabetes, it would come up with glucose, ketones. Yeah, so it is difficult because, as I say, things like weight loss. We know that older cats tend to use body mass more than dogs do. So in some ways, you kind of expect the more senior cats to lose weight. But again, it's kind of having those. It's difficult because I know we always get so we use a call centre for vets now, and not all of them are clinically trained, and they'll hear things like blood, pain, lethargy, and they'll go, oh my goodness, it's the worst thing. And it can be something really minor, and we're like, oh yes, they said bloods, didn't they? That's where you've come down. But from a nurse point of view, it's helpful to know things like polydipsy, polyuria probably aren't normal.
A couple of years ago, I was driving home from a school run, and there was a cat that looked a bit drunk. So I could describe it. And then he collapsed in the road. So we picked him up. It was literally a bag of bones. And he couldn't hold his head up or anything. But had loads of all his fur falling out. So I took it to the vets. And they said that he had kidney disease, but they can go old very now. But yeah, he was. But that's what they said.
Yeah.
Wrong with him, but he was really old as well.
Yeah.
So they were like that. He would have that day anyway. How it was.
Yeah. No, it is hard sometimes because the same thing. I always find things, particularly things like weight loss and lethargy, they also tend to be things that owners just assume happened as an animal ages. So same kind of applies if you've got a dog that's really arthritic. Owners might go, oh, they're slowing down because they're old. And you're like, well, yeah, they are, but equally there's an explanation. So I think it's difficult when you get general symptoms, how to pinpoint. And I think that's why it's just really helpful or really important just to be hypervigilant. Is that even if the owner just says, I think they're drinking a bit more, that in itself is enough to go, could be this.
And I can't see the owner would have seen that cat and thought, okay, in any way,
yeah,
it's all bones, all his fur was falling off. It was just, but it was obviously, I don't know if he was trying to get home or what, but he did make it across the road. The owner would have seen how much he deteriorated over that time, surely.
Yeah, It's a good point. I think sometimes one of the challenges is for owners, if you're living with it every day, you sometimes don't see because it's subtle, or you get used to it. Because we had a cat a few months ago that she was completely blind, and the owners hadn't picked up on it. But it's because it had been small changes. So like maybe one day they noticed that she was like bumping into things. So then they were like compensating for her and like moving stuff around. And it was only when we said like she's completely blind, they were like, is she? Like, yeah.
But they know that the home though, like.
Yeah, so she learned. Yeah, so she learnt the home, and they'd picked up on the fact that she wasn't going outside very much, and they'd picked up on the fact that she was getting a bit more vocal, but they hadn't actually put two and two together and realised it was vision. Because I think sometimes, not always, but I think sometimes if you're used to seeing it every single day, you kind of almost like on a weird one, like with weight loss. Like if, like say for example, if you, I don't know, say you've lost half a stone, you get used to seeing yourself, so maybe you don't spot it, and then you see someone else and they go, oh my goodness, you look amazing. You're like, oh yeah, I have lost some weight. So I think sometimes with animals, the same thing with the chronics, that if owners are used to those kind of almost like the slowly, they don't necessarily see it because they're used to they just think, oh, it's normal for that animal. But it's hard. It's really hard. And are you all happy with all these terms? Yeah.
What's azotemia?
Oh, azotemia. So this basically means high urea levels. So azotemia is a nice one to have for kidney cats. You'll see it everywhere, but it basically means high circulating urea. So we describe cats as azotemic. The halitosis, so the bad smelling breath, comes from the urea. So it's almost like the urea is in the system, and as it breaks down, it makes a smell. Cool.
Used to be on everyone when they run some husband.
Definitely. So we mentioned the stages before. So this is the Isfm stages. I jumped ahead, I got too excited. The next slide shows the breakdown, but this is also quite helpful because again, we're dealing with something that I'd say is progressive and doesn't reveal itself to 75%. But what's quite helpful to look at, I'd say, is if you can pull out kind of those subtle things, the things that you can measure, it's a way that we can classify. Now, it doesn't mean you're always going to classify. It's not like you get a patient, you go, oh, you're a stage 3. I'm amazing, give myself a gold star. But because it's progressive, if by chance you pick a patient up and they're at stage 2, then you can almost prepare the owners for the following stages. Or you can put things in place to help to reduce the clinical signs. So and again, still you get our azotemia. So our non-azotemic patients are where everything is normal. There's no change in blood, so they're not presenting with urea or creatinine increase. There is kidney damage there, but the patients are compensating. So as far as we're concerned, and as far as the wider system is concerned, the body isn't recognising that there's any kidney damage there at all, because it's just kind of compensating. It's put in its homeostatic processes. It's starting to like reduce its ability to process waste, but that waste hasn't yet become corrosive, so it's not showing clinical signs. Yeah.
No, it does have a really question. If a cat that is quite old,
Yeah.
what would tell that cat food good? Would that be a neurological thing? Would that be like them eating like butter food?
Yeah, so there's two possible answers there. So it could be that the senility has caused them to become pica. And you can find, like with humans, as you get a cat that does become senile, that they might start eating random things. But equally, you might find that they're actually looking for things that are moister, because they do develop quite a heavy thirst. So if they recognise that things are wet, they might choose to eat them. The other thing that generally cats do, but kidney cats are particularly good at doing this, is that they'll develop food aversions. So if again the urea makes them feel nauseous, if they've associated that nausea with their normal cat food, you might find that they then become they've become aversive to those particular foods. So then they become novel in what they will eat, because as far as they're concerned, the cat food, the biscuits, everything else they normally have, that's why they're feeling sick. So they kind of go, well, I'm not eating that. So then they eat random stuff. But it could be all of the three. They are weird and wonderful. Mild then is anything less than 25% damage. Again, there is a problem there, particularly in the filtration ability of the glomerulus, but the clinical signs aren't seen. And then your moderate is where we've got quite significant glomerular filtration problems. And this is where our clinical signs are starting to be shown. So our patients might be polydipsic, for example, or polyuria. And the important thing is when we do a blood test, they are appearing to have high urea quantities. So they're becoming azotemic. The next slide shows the scale, so I'll move across to that in a second. But this is the key thing, is it will show up on blood tests. It might still be minor. It's not that the vets are like, oh my goodness, they're really, really high levels. But the key thing is that the urea and the creatinine is creeping up. So the kidney is damaged enough that it's not able to process those waste products effectively. And then the last one is, unfortunately, the last stage, which is our stage 4. And this is where the clinical signs are really severe. The azotemia is present. And we tend to keep stage 4 for cats that have been diagnosed with chronic kidney disease. So everything is mapping to suggest they've got that. So this was the chart I mentioned before. This is from the Isfm. And again, those of you that are doing the kidney cats, hopefully you found this. If not, go home and Google it. It'll give you all the answers you need for your assignment. But again, it's this staging. So it's known as iris staging. And what's quite nice is it gets almost the same way to your pain scores and the other scores we're using. It gives you things that are really objective. So if I come this side, with our stage 1, so it says they're non-azotemic, but that doesn't really quantify it. So what they've said is basically if the creatinine is less than 140 micromoles per litre, that is low enough to suggest that that's within normal function. But you're starting to see some problems. So for example, when you palpate the kidney, they feel a bit enlarged, they feel a bit swollen, they feel a little bit scarred. And again, that may suggest, say if we did an ultrasound, it might be that actually the function of the kidneys is becoming quite severe because the tissue itself is scarring or the tissue itself has been traumatized. Equally, we might find when we do a urine sample that they're starting to struggle to concentrate. It's quite diluted urine. But again, it's all very, very subtle. Whereas if we jump to stage 4, our creatinine is over 440 micromoles per litre. So again, it's a specific number that we don't tend to play number games in practice. But if we need something to say, yes, this animal 100% is azotemic, that's the number we're looking for. Same goes for our for the presence of protein. So protein in the urine is described as proteinuria. And what we can also do is we look at the protein and we look to see how much protein and creatinine is actually in the urine. And now, as we said before, protein in the urine is not something we want to see. Normally, protein is filtered by the Bowman's capsule, stays in circulation. So any protein in the urine is a concern. But again, we've got numbers. So borderline, anything between 0.2 and 0.4 would suggest there's a problem. But when they're over 0.4, that's a major concern. And then with our blood pressure, and again, we can match all of these up. So with our blood pressure, our stage 4, they're severely hypertensive. So your blood pressure is over 100, 180. And this, again, is quite a nice one because I would encourage you guys to get practiced on taking cat's blood pressure. Do it. The aim is that you can do it by yourself with the owner, because then it means you can just do it. But this is quite a subtle one, because actually what we used to do a lot of is with your blood pressure. And hopefully if they weren't stressed out of their brains, like if they're stressed out of their brains, it's not going to work. But if we had a nice calm cat in our consult, we could just do blood pressure and just keep an eye on it. And then if we had several cats that, like, I used to quite often, if it came in one day and it was maybe 200, I'd go, okay, come back next month, let's do it again. Then if the next month it's still 200, you go, okay, come back in a couple of weeks, do it again. But then at that point I said, well, can you bring a urine sample in as well? So they're nice kind of subtle things that you can be getting your owners to do that you've got the kind of staging there, but it just means you can keep on top of it. Okay, right. I'm just going to do diagnosis and then we'll take a break, I think. Actually, we'll do diagnosis and treatment and then we'll take a break because we don't kidneys. So first things first, and with any patient, we want to make sure we do a full history and we ask for a physical examination. So again, with the history taking, we can do this as nurses. Physical examination, you generally want to get the vet to do it. But you could, for example, take some kind of TPRs and do a general check over. And then, as we said before, we then tend to think about what other techniques we have that's going to give us that diagnostic information. So the first one is a urinalysis. Now, urinalysis is a really good tool because obviously our animals are producing urine all the time. The one challenge with our Kit Kats is, again, if you've got a cat that's on a litter tray or a cat that goes out in the bushes, it's quite difficult to pinpoint them. So what we tend to go is say to goes, well, here, have some posh litter that's going to not absorb the urine, and then you put it in the litter tray and the cat goes, what the hell is this? And then they go into urine retention. So we've got a couple of options, but again, for these ones, we're thinking more about trying to cause less stress to our cat. So we've got here, what's happening in this picture? Good, yeah, cystocentesis. So we've got, you're quite right, we're going into the bladder to take the, sorry, it is a cystostomy as well, it's a temporary opening, but with the needle, but it's a cystocentesis. So we're going in, taking urine directly from the bladder. Now, again, we can't do this. This is entering the body cavity, so this is a vet that needs to do this. But sometimes, whilst it feels a little bit invasive, if you've got a cat that is not going to pee on litter, and worst case scenario, you've got an outdoor cat that doesn't even use a tray, you're going to cause a lot less stress by getting them to come in and have a cysto than you are to try and get them. And I've had many times we've literally battled with cats, and owners have had to keep, like, so an outdoor cat, they've had to stay indoors, they've had to use litter trays, they won't use the litter tray, they pee on the floor or they pee on the bed, and then they cause themselves cystitis because they're so stressed by it. So this is quite a nice option, but with that in mind, these are the things we're looking for. So specific gravity, why would that be a benefit to us?
See how concentrated it is.
Yeah, good. So it's going to show us hydration, it's also going to show us concentration. So from a kidney point of view, as you said, if our kidneys are not able to filter, then the ability to concentrate the urine is going to be compromised. So nice, easy test. You guys all did them last year with your refractometer. Takes all of 30 seconds. We've got a clear answer. With our dipstick, we're looking for protein specifically. So we have a look and see what protein's there. As I said, we shouldn't be finding protein in our urine. We might then follow up with a sediment. So this was your cytology from last year. And the reason why we do a cytology is because it allows us to see whether there are any crystals or any white blood cells that might be causing protein addition. So if our urine is completely free and yet we're still having protein, that would suggest there's a problem. And then at that point, we send it off to the lab. We don't do this in practice. We send little pea pods off and they'll do a protein and creatinine ratio. So tell us exactly what's in there. In terms of blood, we're looking for a number of different things, but specifically protein again, and then urea and creatinine. So basically this will tell us how well our kidneys are actually filtering waste products. We would also do electrolytes as well, just to see if there's anything else going on. And then thyroxine, if it's relevant. So sometimes we find with hyperthyroid patients, if it's undiagnosed, they may suffer from hypertension, so increased blood pressure, which then may lead to kidney disease. So we don't always assume that hypothyroidism is a concern, but if we've got a cat that the clinical signs have been really vague and all of a sudden it's become a kidney cat, then we would do other things as well. In terms of routine haematology, we just do this to see what the overall health of the blood is. So things like a red blood cell count, a PCV, as well as the presence of white blood cells. And then as I said before, we do blood pressure. So this is the easiest way to do blood pressure. So you have a little cuff that goes on the cat's foot. Most of them tolerate it quite well. I say practice this. this is one where you almost want, so this is the owner, you almost want to be able to do it all by yourself. Now, in terms of how you do blood pressure, there's kind of three main techniques you can use. So there's what's called a sphygmometer, which some of you may already know what that is. But basically you have it's a kind of can I draw it? Probably not. It kind of looks like a remote control, and on one end you've got a cuff, so you've got like a pump that goes up, that pump inflates the cuff, and then on the very top you've got a dial. So what the cuff will do is it occludes the blood flow. So what you then do is excuse me, is you then listen to the flow of the blood, and the point at which you can then hear the blood again is the blood pressure. So it's quite a nice, I'd say it's quite a straightforward technique, but it does mean a bit of kind of faffing around. You've then got, which are so posh, I love them, you've got individual blood pressure monitors that are literally about this big, that you can sit in with the cat and they will do it for you. Or you can, if you don't have that, you can put them onto a multi-parameter, they'll do it for you as well. But the same principle applies. So it will occlude the blood, work out the pressure at which it is unoccluded, and that's your blood pressure. Okay, so in terms of treatment then, got a couple of different options. I've put everything up on this, but as I said before, we tend to find that there is varying levels. The first one that's really, really important for any kidney cat is that they go on fluids, because they're struggling to concentrate their urine. They're struggling to keep fluid within the circulation. So they are generally going to be quite dehydrated, but equally the kidneys are requiring more fluid to function normally because they're not able to maintain and filter the fluid that's in circulation. So that's the first one. The next one then is ACE inhibitors, which you come across these with Emma yet? No, that's fine. We'll come back to those. Basically, ACE inhibitors, really kind of simply speaking, control blood pressure and control perfusion of circulation. But I say, well, I'll give you a couple of papers to read about that. Don't want to blow your mind too much. I always get told off I do too much pharmacology, so keep it nice and simple. Next one then is peritoneal dialysis. So the peritoneal dialysis surgery and the dialysis, these are more kind of referral options. So peritoneal dialysis is basically where we flood the abdomen with hypertonic fluid. Key thing there is it's hypertonic, so it's higher in salts than it is in water. And what it does is it encourages water to be pulled into it. So what you're basically doing is trying to take the fluid from the vascular bed in the peritoneum, so in and around the kidneys, and as it comes across, it pulls out all of the waste products. You then get rid of the fluids, and what you're trying to do is, it's almost like continuing to wash it. So you're trying to dilute the urea and the urea and creatinine to a point that it's no longer a concern. You've then got the option of dialysis, which if anyone's had family where they've had you might have experience of this, but basically the blood is taken out of the body, is cleaned from all of the waste products and pumped back into the body. And then there's a very, very last situation you might consider surgery. Now, what's worth mentioning is dialysis at the moment is only performed by the RVC. And in terms of surgery, we haven't had a successful kidney replacement in the UK. It's not something we commonly do. They have tried it a number of times in the US. There are a number of papers around the US where they would argue that it is 100% successful. Anyone know why we don't do it routinely in the UK? Or what one of the challenges is that it... Yeah, exactly, donors. So that immediately opens a massive can of worms, that actually we don't have a donor register. We don't routinely harvest organs from animals that have passed away prematurely. So whilst you could argue that it's a process that maybe could work, the wider ramifications means that actually we probably don't. So we have never successfully done it in the UK. But as I say, there are papers out there, and there is a discussion about whether you could do it, and certainly in the States they've tried it a couple of times, but it then opens the ethical question about donorship and how we handle it. So really what we're trying to do is, in terms of our long-term maintenance, is keep that hydration going for as long as possible. Try and reduce the blood flow. Try and reduce the blood pressure, increase the blood flow to the kidneys, and keep an eye on the creatinine and the urea. Okay, let's take a break because we've gone. It's already 11 o'clock. Oh, it's exciting. It does fly, doesn't it? So have a 10-minute comfort break, and then we'll move on to. I put that in for you guys to read. It's just a continuing places. Guys online, has anyone got any questions?
What's that?